Silicosis is an incurable but preventable lung disease. Redoubled effort is required worldwide to control known and emerging sources of silica exposure. The recent outbreak of silicosis associated with artificial stone is a stark example of failure to maintain a high level of caution when using silica-containing materials. Where possible, these materials should be eliminated or substituted for safer alternatives, for example by using metal grids for abrasive blasting. When available, periodic measurement of environmental respirable crystalline silica levels is critical to ensure the effectiveness of control measures and adherence with regulated exposure limits. Respirators should not be utilized as the primary means of worker protection, but used only after more effective control measures such as elimination, substitution, and exhaust ventilation. Health surveillance of exposed workers is widely recommended and generally comprises a periodic health questionnaire, physical examination, lung function, and chest radiology. Historically, programs were developed to identify preclinical features of chronic silicosis. The effectiveness and frequency of these measures, in particular use of chest X-ray, have not been sufficiently evaluated to screen workers who have been exposed to high level of respirable crystalline silica from artificial stone and are at risk of accelerated silicosis. Preliminary reports from artificial stone workers noted a significant proportion to have a normal chest X-ray despite features of silicosis on computed tomography. Although silica exposure is one of the oldest known causes of lung disease, it remains a major cause of disease internationally and is on the rise in those workers using newer high silica content materials. Recent outbreaks of silica-associated disease highlight the need for constant vigilance to identify and control new and well-established sources of silica exposure. While there are currently no effective treatments for silicosis, it is completely preventable lung disease. Rhinoscleroma is a chronic, progressive granulomatous infectious disease of the upper respiratory tract. It was first reported in Europe, but is now rarely diagnosed on that continent. The term rhinoscleroma was first coined in 1870 by von Hebra, who described a nasal lesion that they classified as a form of sarcoma. In 1877, Mickulicz described the histological features of this disease in detail and established its non-neoplastic inflammatory nature. Von Frisch identified the causal agent of the lesion in 1882 as a gram-negative Coccobacillus, now known as Klebsiella rhinoscleromatis. Difficulties in reproducing this disease by inoculating animals with this bacterium prompted questions about the etiological role of this organism in rhinoscleroma, which remained a matter of debate for many years. Finally, in 1961, Stephan and Smith demonstrated that Klebsiella rhinoscleromatis conformed to Koch's postulates and was an etiological agent in the mouse model of an inflammatory reaction mimicking rhinoscleroma. However, little is known about Klebsiella rhinoscleromatis. From phylogenetic point of view, Klebsiella rhinoscleromatis is a subspecies of Klebsiella pneumonia, a gram-negative, non-motile, encapsulated bacillus that belongs to the subgroup of Klebsiella, Enterobacter, and Serratia of the Enterobacteriaceae family, characterized by a positive Vogt-Proskauer reaction. Klebsiella rhinoscleromatis can be differentiated from other subspecies on the basis of biochemical characteristics and has the characteristic somatic O-antigen capsula, K-antigen antigenic combination. Klebsiella species are widely distributed in water, soil, and plants. Humans are the only identified host of Klebsiella rhinoscleromatis. This bacterium is not a typical resident in the airway tract and the skin microbiota, so that it has been isolated only from lesions of the human airway mucosa. Transmission results most probably through large amount of contaminated airborne particles which are expelled by coughing and sneezing or by contact with contaminated fomites. Several risk factors have been associated with rhinoscleroma. This disease is more frequent among people in the second or third decades of life, living in crowded conditions, rural areas with poor hygienic and nutritional conditions such as anemia, for iron deficiency, and also in women. The presence of Klebsiella rhinoscleromatis is not enough for the development of the disease. Since contact for many years of a patient with healthy individuals may not necessarily bring about the infection in the latter. This has led to the suggestion that susceptibility of the host is important to develop the disease. Cellular immunity is probably impaired. Peripherally, there is a reduction of CD4+ lymphocytes and a significant elevation in the numbers of CD8+ lymphocytes, so the CD4-CD8 ratio into the lesion is decreased, possibly inducing a diminished or altered T-cell response. The humoral immunity response does not control the infection, probably due to the intracellular nature and copious mucin code of the bacteria, or due for non-specific nature antibody of the response of the host. Whether these defects are acquired after infection or already present in predisposed individuals remains uncertain. Chronicity of the disease is still not well understood. After mucosal invasion by the bacteria, the acute inflammatory response is inefficient. The neutrophils phagocytize Klebsiella, but appear to die too soon before digestion finishes, releasing viable bacteria. Histiocytes continue with phagocytosis and their phagosomes undergo massive dilation. They thus become Mickulicz cells, which are unable to destroy Klebsiella rhinoscleromatis and eventually rupture, releasing the bacteria into the interstitium. The altered proportion of CD4+ and CD8+ lymphocytes in the lesion may produce disabled macrophages, allowing bacterial multiplication inside them and an ineffectual delayed type hypersensitivity response. Klebsiella rhinoscleromatis possess several important resistance characteristics, such as a complex capsule covered by fimbrial pleomorphism and the ability to grow vigorously both intra- and extracellularly. Clinically, rhinoscleroma is a slow, progressive disease with insidious onset and indolent course affecting primarily the nasal cavity in 95 to 100% of cases with or without involvement of the nasopharynx, nasal sinuses, pharynx, larynx, trachea, and bronchi. Isolated laryngotracheal rhinoscleroma without nasal involvement has been rarely reported. The disease usually presents in the second and third decades of life with a female predominance. It passes through three sequential but overlapping clinical pathological phases: catarrhal, rhinitic, granulomatous, florid, and sclerotic, cicatricial. The patients presented at initial catarrhal phase have features of non-specific rhinitis that evolves to chronic foul purulent discharge, repeated epistaxis, nasal obstruction, crustation, and granulation as granulomatous phase develops. The clinical features of nasal rhinoscleroma are most prominent during granulomatous phase that usually develops several months or even years after infection with frequent remissions and relapses. If not treated early, the disease progresses to the final sclerotic phase where permanent complications including nasal deformities, anosmia, oral anesthesia, dysphonia, dysphagia, and stridor could happen. The presenting features and imaging techniques provide a presumptive diagnosis of rhinoscleroma, but Histopathological examination remains the mainstay for final definitive diagnosis. Cathedral stage shows a non-specific subepithelial infiltrate of polymorphonuclear leukocytes shown by the arrow and squamous metaplasia shown by the star. The diagnostic histological changes of rhinoscleroma are only seen during granulomatous phase. This includes dense infiltration by lymphocytes, plasma cells, Russell bodies, and pathognomonic large Mickulicz cells, foamy macrophages with numerous cytoplasmic vacuoles containing viable and non-viable Klebsiella bacilli. If numerous, then organism can be visualized within Mickulicz cells by hematoxylin and eosin staining, and this is shown by the arrow on the left picture. However, intracytoplasmic bacilli are best demonstrated by spatial staining using Warthin and Starry on the right picture shown by the arrows, or periodic acid sheaf Gamsa-Gram silver stains. More specifically, type 3 Klebsiella antigen can be detected by immunohistochemistry, and the tissue culture can demonstrate the organism in about 50% of cases, in particular at the granulomatous stage of the disease. Sclerotic stage is the final stage, during which the previously formed granulation tissue is replaced by the dense collagen in the form of fibrosis, which can occasionally result in blocked airways. Extensive fibrosis and less inflammatory cell infiltration are the main histological findings in the fibrotic phase, shown on the picture by dense collagen fibers, and this is shown by the arrow. Specific diagnosis is made by the bacterial isolation by culture on blood or McConkey agar, and by identification of histopathological features and bacilli in biopsied lesion biopsies using periodic acid sheaf, Gamsa, and Warthin Starry stain. These stains, combined with immunoperoxidase staining using Klebsiella capsula type 3 antiserum, increase accuracy and specificity of both histological and bacteriologic diagnosis. Radiography, computed tomography, or resonance imaging rarely lead to diagnosis of rhinoscleroma, although they are helpful in defining the extension of the disease. We are finishing the discussion of inflammation with this condition, and next time we will talk about the processes of regeneration.